Welcome, and thank you everyone for joining us for today's webinar, Fostering Cooperation for Out-of-County Kids, Implementing AB 1299. I'm Farrah McDaid Ting. I'm CSAC's Legislative Representative for Health and Behavioral Health. I'm joined today and very thankful by two experts on AB 1299 as well. To my right is Kim Suderman. She's a retired Behavioral Health Director from Yolo County, and she is a consultant for the County Behavioral Health Directors Association and works primarily on children's issues. To my left is Diana Boyer. She's a senior policy analyst with the County Welfare Directors Association of California. She's been with CWDA for almost 14 years and also works primarily on children's issues. Does a great job there. We're so thankful for them to be here today. This is a joint webinar with CWDA, CBHDA, and one person who's not on camera is Rosie McCool from the Chief Probation Officers of California. She couldn't be here today, but as you'll see on our slides, this webinar was jointly developed by our four associations and represents a collaboration by our four associations to help implement AB 1299. And believe me, it has taken all four of our associations to get this far. Today, we will be covering a lot of ground, and so we're going to be working pretty quickly. For the webinar structure, we'll be doing an overview of what AB 1299 is. We'll be doing the key terms of AB 1299, which are important to know. And then, of course, we'll cover the challenges of implementing AB 1299. Those include coordination and communication, and of course, fiscal challenges. And then we'll get to the question and answer section.
So let's talk about the what presumptive transfer is with AB 1299, the responsibility for Medi-Cal specialty mental health services for foster youth. And so these are children placed by child welfare or probation in another county outside of their county of jurisdiction. And so this responsibility transfers Medi-Cal specialty mental health services to the mental health plan where the child resides.
And next I'm going to go through some of the key terms that have often been used in AB 1299 implementation. And the first one is around presumptive transfer. And presumptive transfer boils down to the requirement that the responsibility for providing and arranging for specialty mental health services is to be promptly transferred immediately from the county of origin or original jurisdiction to the county in which the foster youth resides. This also comes with the responsibility for the payment of those services. Presumptive transfer can be waived, and there are four circumstances under which the waiver can be invoked. Those four are listed there and includes when the transfer would disrupt the continuity or delay services, when it would interfere with family reunification efforts, if the child's placement is expected to last less than 6 months, and if the child is within 30 minutes of travel time to his or her provider. Those four provisions for a waiver were negotiated by our respective associations with the bill sponsors, and so we're really pleased to be able to work with the bill sponsors to effectuate that waiver provision because we felt like there really were some special circumstances unique to the needs of the children and families in order to serve their best interests when a waiver should be invoked. It's important to remember that the county of jurisdiction and the placing agency makes that determination of whether or not that waiver should be invoked. And that should at all times occur in consultation with the child and family team. The county of jurisdiction, when we use that term, simply means the county which holds the child's case, the probation agency or the child welfare agency. The next term we often use is the county of placement or the host county. And this is simply where the child resides or the youth resides. Sometimes we refer to this as the residence county. When we talk about the county of placing agency, we're talking about the child welfare services or probation departments who are retaining the responsibility for the care, custody, and control of the youth. Of course, responsible for arranging for living arrangements, overseeing the child's case plan, coordinating other entities, and ensuring the oversight of the child's health. It's important to keep in mind that according to the State Department letters, also known as ACL 1860 and MHSUD 18027, that there's notification requirements that go along with the transfer or waiver provisions of AB 1299. Rather than going through those waiver notifications or other notification requirements, we simply ask that you consult those two all-county letters for further direction. And finally, we have the County of Placing Agency Behavioral Health Departments. While they do not place, we do consider them important partners in terms of ensuring that we're communicating with them, ensuring that the child's interests and needs are met, ensuring screening and follow-up assessment of those services that the child may need, regardless of where the child's residence is. The next key term is STRTP, short-term residential therapeutic programs. And those programs were established under AB 403, the Continuum of Care Reform effort. Something to keep in mind is that at the same time as we were establishing AB 403, 1299 came into play. Group homes were starting to convert to STRTP starting in 2017, which is when essentially the time period when we were starting to implement 1299. STRTPs were intended to be short-term placements. We really, in that law, were trying to reduce not only the use of congregate care through how many kids were placed into those facilities, but also reducing the time in care, ensuring that they were receiving intensive therapeutic integrated services between mental health and child welfare and probation. As we'll discuss a little later in the presentation, there has been some complications resulting from the implementation of these two laws, which we will continue to work through. Next slide, on slide 13, is the STRTPs, just some basic requirements, and many of these are mirrored in federal law that will be implemented in California in the near future, the Federal Families First legislation. The STRTPs must be nationally accredited. They must have programs that include some core services, primarily around transition as well as mental health. And they have to obtain a mental health program approval through the county Department of Health Care Services or through the local county behavioral health agency, as well as a mental health contract. Now, this last bullet has resulted in some complications as well, because many are still in process of doing and so. So we're not seeing the integrated services that we'd expected to see from the STRTPs. That will still need to be developed over time.
And it's true, Diana, the STRTPs are a fairly new concept. So the intersection between Continuum of Care Reform and STRTP model and AB 1299 are happening in parallel. And so the challenge is to integrate those concepts. We're going to move on to the challenges of AB 1299. Our associations, the four associations sponsoring this webinar, worked with the bill sponsors. As Diana noted, counties were responsible for asking for the waiver, the reasons to waive presumptive transfer, and a few other technical pieces of the bill. And now we're working with the sponsors, the legislature, and counties and providers to implement AB 1299. As we've done that, we've run across two sort of buckets of challenges. And one we put in the bucket of coordination. It requires close coordination and communication, whether you transfer a child or waive the transfer of a child. Both instances require a lot of communication and coordination. And then fiscal concerns. There's always been a question as to which county pays for what. And really the idea of AB 1299 and presumptive transfer was to ensure that children would get needed behavioral health services as soon as possible. And so AB 1299 attempted to answer that question. However, that question hasn't exactly been answered, and we'll talk about a few of the fiscal options later in the presentation. For roles and responsibilities, Kim will walk us through that.
Yeah, so child welfare and probation are the placing agencies, and as they place the child or youth, there are requirements that they have to do as they oversee the placement. So one of them is that they're developing the child's case plan, and they've been doing that for years and will continue to do so. They're also shepherding the child through the judicial process, and that can be a challenge. And with the lovely advent of JV 220s that happened a while ago, there's multiple times they're going back to court, particularly when a child is on psychotropic medication. They're ensuring that the child and family team meets and they are an important player, as well as the child and the family and the other service providers involved and the significant people in the child's life. And those are really important partners to be a part of the CFT. Then they're finding and overseeing the placement. So as they look for a place for the child to live while they're getting the services that they need, it's really critical that they find a good match. They're ensuring the health and safety and education of the child and all of the services that the child needs. So this requires a significant level of coordination, and 1299 with presumptive transfer, it requires the caseworker to generate notifications to the child and family team, the mental health plans, the MHPs, and the court regarding the provision of the specialty mental health services. They're determining whether a waiver of presumptive transfer is in order based on the child's needs and the items that Diana outlined just a few minutes ago. So they're looking at that decision, but they're doing that in concert with the child and family team, all of the members, and this needs to be discussed during the CFT meeting. They notify once the child is going to be placed somewhere. If the child is placed out of county, they are going to be notifying the mental health plan where the child is presumptively transferred if they determine that a presumptive transfer should continue. So they would notify the host county, the county mental health plan of residence where the child's going to be, and they will also notify the mental health plan in the county of jurisdiction if the child is going to be waived. So they're going to make sure that both those mental health plans understand who's responsible. That makes a big difference in coordinating the care. And then they're going to update the case plan as necessary.
Great, thank you, Kim. Diana, do you want to add on and then go over information sharing?
I will only add on to that slide that I think the idea that we want to convey is that there really needs to be an upfront investment in the information that's shared so that we're making decisions in the best interest of the child and the family, that we're having continued services and no services disruption for that child. As we know that when a child comes into foster care, there's some immediate needs oftentimes that accompany due to the traumatic impact of the abuse and neglect that they've experienced, as well as the separation from their family. And so it's very important that we work together, we talk together, we're constantly communicating, that CFT is convening so that we're sharing information, determining what's the best interest. I will also underscore that notification between the county child welfare and the residence county MHP does need to happen regardless if specialty mental health services are being provided. That is something that's articulated in the DHCS and DSS letters. So with that, with respect to the information sharing, there's some specific elements that need to be conveyed between counties, and that is essentially the identifying information about the child, the name and location, contact information for the referring placement agency, the most recent court documentation around the medical rights holders, information around who can sign the releases of information. Very important so that we can start those services. Any JV 220 information if the child has medications that need to be administered. And of course, mental health records. And the responsibility for the child welfare agency or the probation agency is to simply ensure that those records are getting transferred. Now, whether the county mental health plan is making those records exchanges or if it's child welfare agency, really that decision is deferred to the counties individually.
And then I just want to add on in relation to that slide that there is an important difference between consent for treatment and release of information. And so both of those, and they may be different entities depending on who has the authority for the pieces. So those are two separate documents and two separate signatures required.
We'll go on to an example now. Kim?
Yeah, so for information sharing, one of the questions we're frequently asked is, what if the host county mental health plan is seeking additional clinical information? This is really common, mental health plans, so that they know where to head with the child. They always would like to see past information. The mental health plan should be contacting the county of jurisdiction mental health plan or any other providers that had been serving the child. They can contact those providers directly and ask for additional information. It's important to know that releases, the only entity that can release actual documents and information is the entity that generated those documents. So if they need psychiatric hospitalization information, mental health plan would contact the hospital. If they need information from a provider that's contracted with the mental health plan, they could go directly to the provider or to the mental health plan in that situation.
Great, thanks, Kim. We'll move on to the next slide, slide 19, on additional communication challenges.
Yeah, so we know that there's always additional things that come up. So there's variation in counties from county to county on policies, and so who can consent for signing releases is really critical. And some counties have different policies about what they would like to see, which may be different from county to county, and versus what's the minimum requirement. So in some counties, the foster parent may have been allowed to give consent. In other counties, it must be the placing worker. So it's really important to know who must sign versus who may sign. And those are big differences from county to county, so please make sure that you're checking on those things. The mental health assessment has to be completed, and also as a placing agency, do make sure you know what mental health services are available as you consider whether you're going to presumptively continue the presumptive transfer or whether you're going to do a waiver, also within the parameters that Diana outlined earlier, but also based on what's available and the child's needs.
Thank you, Kim. Our associations are working to get a clearer sense of the answers to these questions and challenges. We're seeing some questions as well about will there be maybe a standard form, a standard package, and DHCS and DSS have been working on that. We've been consulting on that a little bit. Everybody had hoped that those would be completed by this time. They have not yet been, but efforts at standardization should be helpful. Again, as Kim noted, each county will choose whether to kind of use those standard forms or not. Now we're going to move on to the fiscal issues. Once the host county mental health plan is informed of the presumptive transfer, they must provide or arrange for and pay for all medically necessary specialty mental health services for the foster child youth. Now, foster children are all entitled to specialty mental health services under the EPSDT program. And so, as Diana noted earlier, even when a county of jurisdiction places a child in another county and that child may not yet be receiving specialty mental health services under EPSDT, the county of jurisdiction needs to notify the county mental health plan in the host county because that child is entitled to those services. A child's child welfare services or a probation case and related administrative services and duties and costs remain with the county of jurisdiction. So the county that removed the child from the home retains that placing agency responsibility and it is tasked with ensuring that the child, wherever they place them, gets the necessary services. When a child is placed in another county, then it's a question of how we get that child the necessary services, and under presumptive transfer, the host county provides those specialty mental health services. On slide 21, just to reiterate, again, the whole idea of AB 1291 was to make sure that these kids placed out of county are getting services, because there was a perception that kids were being placed out of county and then being kind of left. They weren't receiving any services, and a child maybe from Alameda County would be placed far away, several counties over, hundreds of miles, and how could Alameda County provide mental health services to that child when they're placed in another county entirely? That was the original sort of initiative behind AB 1299, and what our associations, in working with the bill sponsors and the departments to implement, we affirm our commitment to ensuring that these children get the services they're entitled to, and so AB 1299 was designed to do that. But how we do it is the question, and for the fiscal side of things, we have a couple ideas. One, I'm going to walk through the behavioral health growth formula. We're going to get a little technical here, but it's really important for you to know about. And then there's another option developed by counties, a risk sharing or banking pool. There's also county to counties can speak to each other about services, and then I will reiterate, for a child who is presumptively transferred, that child will be served by the host county mental health plan and will show up in the host county mental health plan's claims or caseload, and that's key. That's important because that's how the behavioral health growth for 2011 realignment, we just agreed on a 3-year formula. And so let me walk through that on slide 22. 2011 realignment has behavioral health services sub-account. And we did not set the growth formula in the statute for 2011 realignment because we had a lot of policy changes happening at that time. And we just recently came to an agreement with the State Department of Finance and the Department of Healthcare Services and Health and Human Services Agency on a 3-year plan for distributing growth from 2011 realignment for behavioral health. And the way we agreed to do it is important. It is 1299 was something that we considered when we developed this formula, and I'll run through it really quick. What we do is we use a 50-50 formula. So each county gets a share of the growth dollars based on this formula. 50% is based on the Medicaid eligibles in that county, which makes sense because if you're eligible for Medicaid or EPSDT, then you're eligible for specialty mental health services should you need them. So 50% is based on that. So that covers the universe of people and children in your county that could be eligible. And then the other 50% we weight it. And the way we weight it is we looked at some data for Medicaid eligibles and found that foster children, because of the EPSDT benefit, oftentimes cost on average 27 more times than your basic average Medicaid eligible person. And the disabled folks cost about 7 times more on average than the straight Medicaid eligible person. So we weight the formula for that. And the reason that's important is if you have a child who's been transferred to your county and you're picking up the cost in your mental health plan, it will show up in your caseload and it will be reflected in this formula. This formula will say, oh, you had 10 foster kids in your county, we're going to weight it by 27, and so you'll receive more funding through the growth formula. The note on that, while it's an elegant way to track it, the note is that growth is not always available. Currently it has been, and so it is responsive to potential 1299 presumptive transfers, but growth is not always available. So that is not a solution that's considered, sustainable. It's not intended to cover the entire costs of potential transfers in your county, but it is meant to be responsible to the costs that counties that are hosting these children may incur. Slide 23 again is very technical, but that formula that I described will be in effect for 3 years. And the growth for the last fiscal year, 17-18, should be going out actually this month or earlier this month. And so it's based on your claims from 17-18. So if you had kids presumptively transferred to your county in, say, January of 2017 or of 2018 of this year, it should show up in your claims and be reflected in your growth. The other option we have on slide 24 is Cal Mesa. Cal Mesa is the California Mental Health Services Authority, which is a JPA that was created by counties after the passage of Proposition 63 in 2004 to help counties actually do prevention and early intervention programs in the mental health sphere. Cal Mesa operates other JPA-like services for counties, and one proposal they have that is up and running is the Cal Mesa Member Transfer Program, where counties may voluntarily contribute funding to a banking pool, and then when you have a child transferred to your county, you can draw from that banking pool for those costs. As of October 18th, and I think there's been 2 or 3 more counties have joined in the last week, there were 9 counties with more than $1 million on deposit through this banking pool. Next, I'm going to throw it to Diana for some other challenges in AB 1299.
Where we hear the most challenges in the area of counties that are placing in other counties STRTPs. And unfortunately, sometimes this has to happen where we place a youth in another county because of the services that are provided by a provider, or perhaps in the county there is no room, or because there are certain other requirements that need to be met, specifically on the probation side. Mm-hmm. And so where we see some challenges are with contracts that for mental health have not been put in place for various reasons. It may be that it's very much still in process. As you know, we have many group homes that are still converting to STRTP. It may be that within that county, they have not yet contracted for their own services yet. Or it may be that there's no plans to contract with that provider for quality reasons. And those are all valid reasons, and we continue to work through that as we implement CCR and STRTPs. It does run somewhat counter to the foundational work of CCR, which is we really want and expect to have integrated services, trauma-based, informed care in these facilities. That said, these are facilities that are intended to be short-term placements. Before I move on, the other challenge we also hear is that because of the uncertainty around mental health contracts, we've been hearing of pressures that have been out there from providers, from counties, concerned around the contracts, the billing, and perhaps just basically wanting to ensure that the care is integrated and all provided from that one facility. So on the next page, there is a provision that, again, we negotiated with the bill sponsors around allowing a waiver of the transfer of the mental health responsibility on a case-by-case basis based on the needs of the child and the services that they need. Because of the very nature of STRTPs, they are intended to be short-term placements, 6 months or less. It may be impossible, we may not all have crystal balls to know exactly how long a child is going to need that therapeutic environment in order to step down. But that is certainly one option that counties have to not transfer the mental health services presumptively. The argument being that there is an expectation that the youth is going to return back to their communities of origin, and we would want that continuation of services. That may not always be the case. There is also provision that if the placement goes beyond 6 months, that the county may consider an extension of that waiver request. Again, it's intended to provide that flexibility on a case-by-case basis so that ultimately the child's service needs are met.
As counties and mental health plans and providers are looking at working together as an STRTP, the mental health plans and the STRPs work together in an agreement. And so, but as Diana explained, there are situations where the county mental health plan may not have a contract or may not be contracting with the provider. That doesn't relieve them of responsibility for services for the Medi-Cal beneficiary that has been presumptively transferred. So they must still make arrangements for services. There is no requirement for the mental health plan to contract with any specific provider. They may select, that is their right as a delegated responsibility of Medi-Cal specialty mental health services. But the hope is that in most situations, they would be contracting with the provider where the child resides in their host county.
And again, a reminder that STRTPs are a generally new classification, and
Yes.
they're being approved and examined and
Right.
getting licensing, and so we're all learning together on this. And so
they're learning how to do Medi-Cal, which
Yeah.
is a lovely challenge in and of itself. But the mental health plan is still responsible to make arrangements for or provide services themselves.
Great.
Yeah, so the STRTP, we know that the providers have multiple, this means they're going to have multiple contracts. They're going to have a contract hopefully with the host county, and they certainly may have contracts with other counties, particularly when a waiver is put in place. And so that does mean multiple contracts, which we know is a challenge for the providers. And then we know that there's questions about what happens if the child is placed out of county in an STRTP and the mental health plan does not contract. So I kind of referenced this earlier. They still have responsibility to make arrangements for that beneficiary, because that beneficiary is now theirs. So the host county has responsibility to serve directly or make arrangements for those services.
Moving on to slide 30 on hospitalization. A quick note about that from Kim.
Yes.
Yeah.
So hospitalization, psychiatric hospitalization, is still a component of Medi-Cal specialty mental health services. So that transfer goes with them. One of the challenges is in the meds program, the hospitals still will see the county of jurisdiction Medi-Cal listed. So they will continue most likely to send their invoices to the county of jurisdiction. So it will be important that the host county notify the county of jurisdiction when a child has been hospitalized, because they will need to coordinate the payment to the hospital for that?
So I think what we've heard also is there's a desire for some automated way to really track when these transfers occur. Because obviously kids can move frequently between counties depending on their case plan. So right now at this point there isn't a very easy way to track this. You might be able to see something in meds that indicates that residence address is somewhere else and might or may not be able to presume anything from that. So there was an earlier indication that DHCS might be pursuing some changes to meds, some sort of an indicator. At this time, we're not aware of any efforts, and so we'll continue to work with the state departments to see if there could be some automated solution to help counties with the tracking.
Great, thanks, Diana. On slide 32, we want to point out that this is something that's been worked out in regulation with the departments and other stakeholders. Each county, to facilitate the communication and cooperation, maintains a single point of contact within the child welfare, probation, and behavioral health. And so this slide shows you the resources, but these links are also on the resources page for counties to review. It's really important that counties know who to contact, and if you don't know anybody in the other county, this will be the person to call to try to get you to the right person. We really saw that was something that was desperately needed, and so those lists are maintained by the departments but are based on the information that counties send to them. So be sure to update if your person changes or moves or something. Please update your single point of contact. It's a key component to counties communicating with each other. I want to note that we'll post all these resources, including recording of this webinar, on our webinar website, so you'll have all of this information available to you. And now we're going to move quickly on to the question and answer portion of the webinar. The first question we have is related to somewhat kind of the contracting issue, I would say, where the question is, we understand some counties are reaching out to the STRTP and neighboring counties to contract with them with plans to waive presumptive transfer. Is that an acceptable approach? It's true, in this question they mentioned that presumptive transfer is assessed on a case-by-case basis. You cannot say that all children that are placed in a STRTP, for example, are automatically waived a presumptive transfer. It's a case-by-case basis. And STRTPs, like we've said, are intended or were designed for short-term stays of 6 months or less. That's the design and the goal of CCR, to make sure that children are away from their families and their other support systems in their host county or in their county of jurisdiction for as short a time as possible. They're high-end therapeutic placements, but children can be there for longer than 6 months, and every 6 months that needs to be reviewed. And if the presumptive transfer is waived for a child placed in an STRTP, that needs to be reviewed every 6 months as well. So just want to put that clarification in there, that STRTPs, while they're designed to be for stays of 6 months or less, that's the therapeutic design, we understand, and there's nothing in statute that says that it's limited to 6 months or less.
And I will just add that I think that potentially is a proactive approach, because first of all, if you can't place the youth within your county, placing them in the neighboring county is probably your next best alternative, because that provider may be relatively close to continue with family reunification services or to help with the transition and step down. It's possible that could meet the other criteria for a waiver, which is provision of services within 30 minutes. Now, we know counties are large, and that may not be the case, but that's also another piece of it. And third, what wasn't in the slides, but just important to note from the law, is that not only do you have to meet one of the criteria for the waiver, but you also have to demonstrate an ability to contract with that provider within 30 days. And so you will have met that by doing so.
Yeah. And it is possible to make those arrangements, but they're not kid specific. They would have that available contract, so that when they place a kid and on a case by case decision decide to waive, then the contract would be ready to go.
Yeah, and so that's the goal for maybe contracting with neighboring STRTPs in neighboring counties. We have a question about consent. I think we answered that question as far as there is a form underway in development, but it's not quite ready yet. But again, having a standard form will really help. However, it is a county by county decision on whether to use that form. We have a question about the hospital question, which I believe we answered. So Jeff, can we move on to other questions, please? So again, we have another question about when you have a presumptive transfer, how do you know who the single point of contact is? That last slide that we showed and in our resources page is the list of each county's single point of contact. So you can refer to that. It's on the DSS and DHCS website. You can refer to that to find the list of the person that you should call. There's a question about timing. Once a child is placed in a host county, how many days does the host county have to link the child to mental health services? Kim, is there a day requirement? I can't remember.
No, you're informed and the child should be, so part of it is the being informed, that's the first piece, and then beginning to make arrangements. So I can't think of a specific time frame, but we know it is short because the child is only supposed to be there for 6 months. That's the intent. So services really should be starting to be arranged immediately, but the assessment, if there hasn't been an assessment, one needs to be done, and sometimes waiting on records could delay that process as well.
Yeah, and so we anticipated that, sorry Dan, in the statute a little bit, saying that a host county can use the assessment done by the county of jurisdiction if they had already assessed the child to speed that process, or the host county may do their own assessment. Either way, as Kim mentioned, we want to make sure that the child is getting services as quickly as possible. So that's the goal.
And I will just add that there are general standards by which mental health plans operate for time and distance and timely access to services.
Yeah, and each county has that. That's a part of their regular plan. That's the agreement, and DHCS will have already known those standards that each county has set.
Okay, we're looking at other questions here. So we're talking about minutes read or redacted from the court order. We'll have to do a little more research on that as far as the consents.
No, I think you're talking about the minute orders for consent, for who can sign the consent.
Okay.
So it looks like the question is about who can sign the consent if a county doesn't accept the minute order from the county of jurisdiction that says a specific person can be sent. So that is an individual county policy piece that probably needs to sort out county from county to county, and really I think in that situation probably a contact with your CBHDA and CWDA liaison or CPOC liaison, and we can probably help sort that out.
And once we have the template for a standardized consent form, I think we could also use that opportunity when we share that information with counties to engage with all counties, including county councils, to ensure that there are no hiccups in terms of what's accepted or not acceptable as far as documentation.
Great. Our next question is about when the presumptive transfer notice, when a host county receives the child, can they start billing for that child, or do they put that child on their caseload as soon as the child is placed, the date of placement, or the date of their notice that the child is there? Under 1299, I believe it's 3 business days for the placing agency to notify the host mental health plan. And so the placement could happen 3 days before that, but once you're notified, you need to get the ball rolling, and you can, that child can be presumptively transferred, and you can bill for services that you're providing that child.
Basically, as soon as you know that the child is your responsibility, go for it.
Yeah. Great. We have a question about the behavioral health growth formula and how 50% is based on a county's Medicaid caseload. It includes all Medicaid eligible persons in that county, even if they're not receiving services, but they are signed up for Medicaid or Medi-Cal here in California. That's the caseload that we're talking about. So it includes counties' existing foster children in the county, children that are transferred to the county, and all other Medicaid eligibles of all ages.
There was a question around wraparound that was deleted. We can bring that back perhaps.
Yeah, it was more about full service partnerships, which is typically an adult services on the behavioral health side.
Well, no, there's full service partnerships through a Mental Health Services Act for children that look like wraparound, and or it could be wraparound services. There's no requirement. We don't bump children who are already being served off of out of services to put another child ahead. So we know that there's limited services and limited resources available. So that would be important for the placing agency to know that while they want to presumptively transfer and access a service, there may be a limited availability based on human resources. Not that no services would be provided, because we're responsible to provide medically necessary services. But it may be that a specific program may not be accessible immediately.
And thank you. So I was just going to say, we just want to make sure that we're clear on the distinction.
Yes.
Because there may be a wraparound contract with the provider to provide wraparound services, but there are also specialty mental health services, and under EPSDT, our foster youth are entitled to those services. There is no waiting list. And so there may be a wait list for a WRAP program, because certainly counties do pay for those WRAP programs themselves, either through MHSA or through county child welfare realignment dollars. And so those, are contracts for services. But the mental health piece is separate, and so those would be separately addressed.
Yes.
Great. Well, thank you. We're running up against time. Our contact information is on the webinar and on the slides as well. I want to thank Kim and Diana for making time to do this today. I want to wish everybody out there happy Halloween. I hope you're having a great day, and thank you for joining us for today's webinar.